Hey, good morning. My name is Mike Katzen. I'm a third-year general surgery resident at Carolinas Medical Center in Charlotte. I'm happy to be here today discussing our study, the impact of enterotomies during laparoscopic ventral hernia repair. Let me go full screen here.
Yeah, can you guys,
Thank you. I have no disclosures. The other disclosures are listed here, but there are no conflicts of interest between authors in our study. The laparoscopic ventral hernia repair is associated with fewer wound complications and shorter recovery times compared to open techniques. But some studies also report higher rates of intra-abdominal injuries, such as enterotomies. Enterotomies in this study, and I'm sorry, this is automatically forwarding here. Maybe you can help me adjust and go backwards. Enterotomies in our study are defined as a full-thickness bowel injury and represent a significant challenge as they can require conversion to open procedure in order to address and can introduce contamination to the surgical field. Sorry, could you help me scroll backwards here a couple slides? The largest study to date to primarily analyze the incidence and impact of enterotomies on laparoscopic ventral hernia repairs was published in 2007. And in this review, the rate of recognized enterotomies was 1.5%. Furthermore, enterotomies were associated with a significant increase in mortality. And therefore, the purpose of our study was to further establish the incidence of recognized enterotomies during laparoscopic ventral hernia repair and understand the impact on short-term outcomes. We searched the National Readmissions Database between 2016 and 2018 for patients who underwent laparoscopic repair of a ventral hernia. We then created a group of enterotomy patients by identifying ICD-10 codes, which indicate accidental injury to the GI tract during the procedure. We compared patients without a bowel injury against those in the enterotomy group, and then performed multivariable analysis of risk for readmission. And here we see some of the results. So there were over 30,000 patients who underwent laparoscopic ventral hernia repair during this time frame, and 388 identified in the enterotomy group. The incidence is calculated on the left, and so the total rate of enterotomy was 1.29%, and there was no difference in incidence between elective and non-elective settings. In the table, we can see the comparison between patients without an enterotomy and those in the enterotomy group, and this is further defined or stratified into elective and non-elective patients. Starting with elective patients, we can see that those in the enterotomy group were slightly older, but had no differences in comorbidities as measured by the Charlson Comorbidity Index. Enterotomy patients did have significantly increased in-hospital mortality, longer length of stay, higher hospital costs, and higher 90-day readmission. In the non-elective cohort, we saw no difference in age or Charlson Comorbidity Index between these groups, but again, an increase in short-term outcomes for the enterotomy patients, such as in-hospital mortality, length of stay, cost, and 90-day readmission. Further analysis of readmitted patients is shown on the left-hand side, and looking at readmission diagnoses, we can see that the most common readmission diagnosis in both groups was infection, but enterotomy patients experienced this at a higher rate, so 4.1% of enterotomy patients were readmitted with an infection compared to 1.9% in the group without an enterotomy. There was no difference in readmission with ileus, but enterotomy patients were much more likely to represent or readmit with intestinal obstruction. Furthermore, analysis of reoperation rates at 6 months shows that enterotomy patients were more likely to require operation for that obstruction. There was no difference in operation for hernia recurrence at a 6-month time frame between groups. On the right is the multivariable analysis of readmission risk, and we can see that the following covariates were significant, and so increasing age, non-elective status, higher Charlson Comorbidity Index, and longer length of stay all increased the risk for readmission, while in this model, enterotomy did not. And so, in summary, laparoscopic ventral hernia repair was associated with low morbidity and mortality, but enterotomy occurred, a recognized enterotomy occurred at a rate of 1.29% and was associated with worse short-term outcomes and a change in readmission patterns. Thank you. I'm happy to answer any questions at this time.